I'll just review some of the general guidelines and recommendations how to report results, which can be useful for you if you're writing up a study, so that you write a good manuscript. It's a good paper. It will be well received. But you can also use these guidelines to critically assess studies written by someone else. If they didn't follow these recommendations, maybe they're hiding something, maybe they just didn't pay close attention to what should be reported. But without reporting certain aspects of each study, you as the reader should always be skeptical. Is this study done correctly? And if it's not clear, then the validity of the results is at least questionable. So for the absolute musts in cost-effectiveness analysis, always specify the perspective, because the perspective really dictates so much what types of costs you included, excluded, what types of health effects you included or excluded. So perspective is absolute must that has to be reported. The recommendation of the second panel on cost effectiveness is to do the analysis from healthcare sector and societal perspectives at the very least. If you want to do it from the patient perspective, sure, go ahead. But for comparison purposes, the two, healthcare sector and societal, should be included as well. Then in the results, we should always report the total cost for each strategy, the total effectiveness of each strategy, incremental cost, incremental effectiveness, incremental cost effectiveness ratio. Essentially the CEA table we had in the Excel spreadsheet on the last of the three sheets. And now some recommendations. If you find that some alternatives are dominated, you don't have to report the answer. You just can say dominated, period. You don't have to report that it was negative 11,000 rupees per quality. That doesn't matter. Another recommendation is that among those alternatives that are not dominated, that results should be reported in increasing order of costs. So from the cheapest to the most expensive. And now I'll quickly cover 10 CEA commandments, originally written by Mike Drummond from the UK. He's one of the biggest people in this field. So let's dive into that. So the first one is, if you're reading a study, was a well-defined question posed in an answerable form? Like if the research question is unclear, then you don't really know what the researchers are doing, right? So both comparisons should be described, all alternatives should be described and justified why these were included. Clear decision-making viewpoint, that's the perspective. I already mentioned that. The second one was a comprehensive description of the competing alternatives given. Keep in mind that doing nothing is almost always an option. If it's not included, there should be a justification why not. For example, if we already know that there is current standard of treatment that works, that is good enough justification for not including, not treating the patient. In this case, doing nothing would mean just doing things as we have always done them. It's important to look at how the researchers establish effectiveness of the interventions. What data sources did they use? Again, RCTs are the gold standard, though they have some limitations. I actually would add, so randomized control trials, the next one would be probably cohort studies, then case control studies, then clinical series. You should look at if the effectiveness was based on a systematic review and ideally a meta-analysis, or if it was just an ad hoc review of a bunch of papers that came up on Google. That is also important. The number 4 were all important and relevant costs and consequences for each alternative identified. So this is when you should sit down, sit back, and think about what are all the costs for this particular intervention that you would personally include, and you can look if the researchers included them as well. Maybe you can think of some other important costs that were not included. In that case, the results may be, or the conclusion may be questionable. It's important to look at if the costs and consequences reflected the perspective. For example, if it was a societal perspective, whether all the recommended items were included. On the other hand, if the perspective was healthcare sector, and the researchers for some reason used some costs that would be only in the societal perspective, that may not be the right approach. Number 5, were costs and consequences measured accurately in appropriate physical units? Maybe I should say in just appropriate units. I don't know how quali is actually a physical unit. Yeah, so costs of time-consuming services usually is a wage times time. But this all depends on each particular question. So now number 6, were costs and consequences valued credibly? When we talk about costs, you can use charges, you can use reimbursements, you can use some proxy for costs. That is important to be described. How did the researchers got to these numbers? Why particularly this number is the cost? And they should be clear about whether it is a charge, whether it is a variable cost, and so on. Next one is whether costs and consequences were adjusted for differential timing. That means, did they use discounting? The recommendation is use discounting for both costs and consequences in the same fashion. So that should be, at least in the reference case, that should be included. If the researchers had a good reason why not to discount costs and or consequences, they can do this as a separate analysis on the side, but for reporting purposes and comparison purposes across interventions, this should be reported as well, discounting should have been done as well. Number 8, was the incremental analysis of costs and consequences of alternatives performed? This one tackles a situation. I didn't actually talk about it this much, but I just told you that results of cost effectiveness analyses are usually reported as the ICER, the incremental cost effectiveness ratio, a ratio of incremental cost and incremental effectiveness. However, you could technically think about why not do simple cost effectiveness ratio? We have, in our vaccine example, we could take the total cost over total effectiveness for vaccine, and then take total cost over total effectiveness for for no vaccine, and then just compare the two ratios, which one is smaller, which one is larger. But I will, I don't think I have a good example of this, but making judgments based on simple cost-effectiveness ratios can lead to incorrect conclusions. Not always, but in some special cases it can. While for incremental cost-effectiveness ratio, they don't. So if the researchers reported simple cost-effectiveness ratio, that is a huge red flag. Only the ICER should be reported and discussed. Number 9, was allowance made for uncertainty in the estimates of costs and consequences? That's what we just talked about earlier today. Like, almost no parameters are ever certain. If the researchers didn't allow for this uncertainty, didn't acknowledge it, somewhat ignored that they are not sure that the parameters will be exactly this number. The conclusion, like the base case, the point estimate of the ICER, may be nice, may be favorable, but if we account for uncertainty, we may find out that the chances of this ICER being the true value are pretty low. So a sensitivity analysis should be always performed. Now the second panel recommends doing definitely probabilistic sensitivity analysis on all parameters that are uncertain at the same time. My personal recommendation is I would do one-way deterministic sensitivity analysis on each parameter separately to get a sense which of the parameters has the most influence on the result, and then do a stochastic sensitivity analysis on all parameters at once. And finally, did the presentation and discussion of study results include all issues of concerns to users? Every study, essentially what this says is every study has a limitation. These should be acknowledged and discussed explicitly, and the results should be, interpreted in a fair manner. Potentially, this is sort of the last bullet point is sort of a bonus, but if the researchers even consider the impact on the budget, great, that's awesome. But I wouldn't say that is a necessary condition for a good study. And I think that's pretty much all I had, but sure.
So if we can go back to the command number 6. So how are we valuing the resources credibly? What does that mean?
So when we talked about valuing costs earlier, we can use the micro costing, gross costing. There are many approaches how to do this, and some valuing may be just like more credible. Like if you read their description, how they came up with this, and it seems that they valued costs by scratching their beards and coming up with a number. That may not be credible. By this I mean, for example, if they use an expert judgment, that may or may not be credible. If they use an expert judgment for costs, then a good sensitivity analysis should have been performed. In that case, that's fine. But if they just use an expert judgment, took one value, plugged it in, and that's it, I don't trust those results.
I want to comment about that ICER. Why ICER is used is that marginal cost concept is there. You should always do analysis at the margin. And very good example of that is famous in economic literature is that stool occult blood test. That paper has exemplified that this thing. If you do stool occult blood test, it helps you to detect colon cancers. So 3 stool occult blood tests will detect some amount of colon cancers. If you do 4, 5 and 6, each test, extra test will help you detect more and more colon cancers. So if you take 6 tests, I think you will almost achieve diagnosing on 99.9% of colon cancers. But the cost of that 6th test, if you take difference between 5th and 6th, between 5th and 6th test, only 3 cases extra are detected. 3 extra cases of colon cancer. And for those 3 cases, you have to do 6 occult blood tests of all the individuals. And that becomes a huge cost for detection of those 3 cases. So that is called a marginal analysis. So if you consider that, then that 6th test becomes obsolete. But if you just take average of that, then it is okay. 6 tests, 5th or 6th test, and divided by all the population, the average is not much. Average difference would come around $1,000, but actual difference for detection of those 3 costs comes to huge around $1 million per case. So it's a paper, it's a famous paper by some guy. 6th, the significance of stool occult blood test in detection of colon cancer. Thank you.
Thank you. Thank you. That was great.
So you mentioned that you prefer to do the one-way sensitivity analysis first and then go to the put all the variables together. But would this apply to both deterministic or probabilistic? Because many papers report both, and they give a tornado diagram. So which one is it applicable to?
I personally would start with deterministic one-way sensitivity analysis on every single parameter individually to just get a sense which parameter has the most effect or influences the conclusion the most. After getting that understanding, I would do a stochastic multi-way sensitivity analysis on all parameters at once using the second order Monte Carlo simulation.
Is there any recommendation? Because in papers, I think it's the way you are mentioning. Is it like that?
If I recall, the recommendation of the second panel is do the probabilistic sensitivity analysis. Definitely. One-way sensitivity analysis are a good option. I think that's the recommendation, if I recall correctly.
Most studies usually tell us not just the effectiveness but also the harm or the safety side of it. How do we do that with costing? I know we've looked at effectiveness and costing with regards to effectiveness with the ICER. How do we look at the harm and the cost related to that? Do you kind of subtract that from the...
Yeah, that's a good question. I guess the incremental effectiveness could give you a good sense, but it's not necessarily harm, right? It's just like a potential effect that was not reached. Yeah, that's a good question. I don't know.
So the toxicity can also be costed in many clinical trials. So that will go into that arm of the study. So in the net, the cost that is accrued, this will get added to the cost, the toxicity treatment cost, added hospitalization, and drugs, etc.
One thing that I would like to add is that you technically can track things in the model. If you're interested in some serious adverse events, even if they're in aggregate, even if they're offset by positive gains, so the net effect is actually positive. If you're interested in tracking like how many people were actually harmed, by this intervention, you can just like add a tracker, and then like if you feel that this is important, you can report that. Now, it would be one of the health states in the model, so you would just keep track of the initial population, how many people were ultimately harmed.
Yeah, I think often when there is an adverse event, the cost is a lot more
Oh yeah.
than with multiple gains from the effectiveness. So, yes. So I guess you put another tracker to say this is.
Yeah, like in aggregate, like the net effect is accounted for already. But if you want to distinguish if there were many patients who had tremendous benefit and some patients who had tremendous harm, the net effect still can be positive, and yay, let's do this intervention. But if you still want to warn the decision maker, like, yes, you will improve health overall, but there will be a subset of people who will suffer, then you can just track that in the model.
When we present this cost effectiveness analysis to the policymakers, they are very curious to know that other parameters. How many deaths can be prevented? What are the cases prevented? Can we get that information from this our analysis, or we have to do it in the additional analysis?
Absolutely. So for that, you would exactly use these kinds of trackers, and you would track how many people ultimately died because of the illness. So that's why in some analyses you can see, for example, if it's a Markov model. In the example that we used, there was one health state for death. When someone asked if we accounted for all-cause mortality, if we would just have an arrow going directly from the health state to the death health state, we could do that. But in some papers, you see that the researchers considered two types of deaths. It's essentially two different health states. They're both absorbent. Like once you get to one of them, you stay there. But this is done only for the tracking purposes, so that you keep track of how many people died because of the intervention. There would be one health state, and then you would have another health state for people who died of just all other causes that had nothing to do with the intervention. So there are like if you want to do this, then you have to. Good idea would be to think about this in advance before you design the model. And then if you design your model in a way that can track for this, then absolutely you can do this.
What about that when we do the Markov or decision tree, that death will come from the last column? Can we take it from that?
Sure.